tibial surface connected to the shaft. And then the 6, which we see a lot of here, associated with body traumas. And the 1's really easy. The 2's can be easy, they can be difficult. The 3's, when you do find a true 3, really hard. 4's all need fixing without exception. Same as a medial femoral condyle fracture, it will be in this place for the first 2 or 3 weeks, and then it won't be, and then you really regret not fixing it on day 1. 5 and 6 all need fixing. This is probably more useful as Confeng Lau's 3-column classification of plateau fractures. And it's very, very simple and orthopod friendly. Medial is lateral, it's posterior. And all of you have probably seen enough plateaus now, or talked about enough plateaus with various consultants, that we tend to not necessarily use this classification, but you think about it when you're fixing it. Because these are the 3 different zones you're essentially trying to fix, or you can fix. You can fix laterally, you can fix medially, and you can fix the back. So when you're looking at the images and you're looking at the scans, you're working out, right, which of the pieces that have moved, where do I need to go, where do I need to go first, of those 3 zones. There's a slightly better, prettier colour picture. That red line is generally where most people would say, you might well have a posterolateral column injury, but I can't do anything about it. So they tend to kind of restrict themselves to the PCL and over for fixation. Hopefully, if you get enough time, or some of the slides will demonstrate, you can get all the way round to the posterior tibial head from a nice, simple, easy off-medial approach. The imaging. Who's going to say there's a fracture there? Okay, John, you can put a finger up. Where's the fracture?
I think there's one in the lateral plateau.
What makes you think that?
Well, it looks like the joint. There's a slight depression in the joint surface. It doesn't look like a completely smooth, articular line on the AP radiograph. I can't see anything.
And you're right. That's a CT. And the key is that the lateral joint line should always be above the medial joint line. So if you ever see preoperatively, it's down, not something wrong. Probably more important when you're fixing it, because it can look absolutely lovely. You think, oh, I've done a nice job there, I've squeezed it down, it looks great, but you haven't actually got the height of the lateral plateau back. So as soon as they stand on it, they're going to drop into valgus, and then they're loading their injured sigmoid plateau. So the lateral plateau should always be above the medial plateau. With rare exception, particularly an isolated lateral plateau injury, you're never going to jack the lateral plateau too high. I have them, but generally speaking, you can't jack it too high. And that's a bit more obvious. So the treatment is exactly no fractures, small fractures. You manage the Pareto principles, these potentially high energy injuries. You go to splint it, you go to document the neurovascular status, always going to scan it, and then you plan surgery. And you are going to respect the soft tissues. So there are most plateaus can be done in the first couple of days. It's not an issue. It's not a peel-on where there's a lot more argument. But there are a group of plateaus, particularly the 6s, which are very high energy injuries. They can take weeks and weeks and weeks for soft tissues to settle. And sometimes with those, you have to accept that you can only do limited fixation. So you might get in on day 1 and do a safe part of fixation, which is usually posteromedial. And then you're going to say, well, I'm going to have to wait until the soft tissues allow me to come out laterally. And that might be 5 or 6 weeks. And 5 or 6 weeks is miserable. Yeah.
Going back to that Confeng Lau classification, you're just saying it's useful just for pre-op.
Yeah, I mean, essentially, it's an optic planning classification more than anything else. It tells you a little bit about how the practice happened, how it's going to behave, and what you're going to do with it. But it's more kind of it's a bit like the topless classification for pelons. It's not that useful saying, oh, this is a Confeng Lau, whatever, or a topless Lau. It's more of these are the fragments that are really important, and these are the fragments you need to identify and work out where you're going to fix them and how you're going to. And I will hold my hand up now. The rest of this talk on plateaus is shamelessly stolen from Tim White. He gave this talk at the OTS this year, and it's probably one of the best talks I've seen on strategies for approaching tibial plateau fractures. So I looked at it and thought there's no point reinventing the wheel. There's a very clever man who's very good at writing talks, written a talk on it, so I will use it. No, I'm credited for it. So what he talks about, and what most of us talk about, is your planning. And your planning is generally with concrete layout, where do you want to place it? Do you want to place it back? More often than not, yes. Now, you tend not to leave those posterior corners or the posterior depressions alone anymore. They do lead on to long-term problems. But where do you need your incisions to be? Do you need anterolateral and posteromedial, or do you need medial and lateral, or do you just need lateral? Can you do everything through a single approach? No, unless it's a 1, 2, or 3. Percutaneous techniques, don't do a lot of them here, because you don't see a lot of that type of injury, but we've got some nice slides, which can be very useful. Frame, personally, I don't see a role for circular frame fixation of plateau, circular fractures. Pelon fractures, no plateau fractures, or pelon fractures, or any fracture, but certainly not articular fractures. You can't, to get the joint absolutely reduced, you have to open it up and elevate it. Once you open it up and elevate it, it's staring at you, and you may as well put a plate onto the hole you just made, rather than having in wires right in the periarticular region. And all fine wires will get infected, or at least colonized. So I don't personally think frames have a role here, but there's always a difference of opinion. So the dual incision, your standard textbook, everyday dual incision will be that. The posteromedial side, or the posterior fracture, tends to be pretty simple. It tends to be a shearing injury. Same as your Barton's and your wrist, same as your posterior malleolus in your ankle. It's usually as the fractures displace laterally and as they flex the knee, they've knocked off the back of the tibia. So it's a very, very simple fracture. And you usually just need a small incision centered over the apex of fracture on your axial CT scan. One thing I would warn everybody, having done all of these and trained in South Wales, there are a lot of fat people in the world. And when you're looking at CT scan, don't look at just the fracture, have a look at the soft tissue channel around it. So if you drew the screw on that you want to put in at the apex, where does that come out on the skin? And make your incision there. Because you don't want to get down to the tibia, be able to see the tibia, or see the fracture, reduce it perfectly, and put a plate on it, and then find out that your drill won't fit without making the incision 5 times longer. So basically just draw the line of the screw on that you want to do on the axial view, where that meets the skin, where you're going to cut it. Tends to be a little more posterior than you imagine. You can do this sort of dual approach easily or supine. You can do the posteromedial side in figure 4. And all you do is that. Right at the back, just over gastroc, make a nice cut, move the gastroc out of the way, and you're staring at the fracture, and you put a little buttress plate on it. As you tighten the screw down, extend the knee so the fracture doesn't displace posteriorly as it will do in figure 4. And that's your posteromedial side done. Most of them we'll talk about more complex injuries later. And we'll talk about the type of anterolateral approach to do. There are a variety, there's no right, there's no wrong. Personally, I wouldn't use a hockey stick and don't like using a hockey stick. It's miserable for any revisions. If there's anything wrong, it just makes everything more difficult. Also, having tried it on many, many occasions, I very rarely ever got the horizontal limb of my hockey stick in the right place. Because even if you mark it out, you make your incision, by the time you've reduced the plateau is now a centimetre north of your incision. And it makes it more difficult. So I would stay away from a hockey stick. And that is why you do dual incisions. That is the dead bone sandwich. There is absolutely no excuse for doing medial and lateral tibial plating for a single extensile anterior approach. There's a lot changed in soft tissue management. There's a lot changed. We get away with a lot of things we didn't used to get away with. That is not all the things we still get away with there. Some of the arthroplasty surgeons will say, yeah, do a single approach, makes the knee replacement easier.
Sorry, can I just say,
Yeah.
if you're going to do medial and lateral, what's the minimum skin bridge that you would have?
There isn't really one. I know a lot of people say sort of 7 centimetres is a nice number to have in your head, and it probably is, and I'd worry about anything less than that. But it's about how you make the approach, and it's full thickness flat, so it's not going in through the skin and then just ripping it apart with your Macintosh scissors. It's going in a nice proper plane from skin, or carefully all the way down to bone. If you leave that anterior skin completely untouched and you haven't stripped it, then you're fine. If you've made your incisions quite far apart and then essentially met in the middle at the front by just undermining the skin, well, that's bad as well. So it's more about how you make your flats than how fancy your incisions are. There are lots and lots and lots of papers out there on tibial plateau fractures, and these are several that Tim likes to comment on. And it is a COP study. Did look at circular fixation versus frame. This is one of the papers that pushed on people to say, oh, you know, you've got to do a circular frame plateau fractures. But actually, you look into it, there's a high infection rate in the ORIF group, but most of them were bilateral, bicondylar plating through a single midline approach. That is not the fault of the plates or the fact they've gone for ORIF, it's the fault of doing a horrendous soft tissue retting approach that you should never do. So that is the paper that most people quote saying, got to put a frame on them, but actually read a little bit deeper into them into why there's a problem. Yeah, so that's a 20% or 18% infection in the ORIF group. And it is a dead bone sandwich. When you're looking at all these kind of studies together, then you look at this one and say, well, these are looking at dual incision plating rather than single incision plating. And it's less than 2%, which is pretty standard for orthopedic trauma, particularly periarticular fractures. So that's showing you that it's not the problem of the ORIF technique, it's the problem of the choice of approach in that paper, which leads to such a high infection rate. The posteromedial approach is gaining more popularity, more people do it, more people appreciate the need for it, and there's a few papers later on that tell you why. And it's very, very simple. If it's a simple pattern fracture, you just approach it where the apex of the fracture is and you buttress it in at the beginning, or I do, because you turn then a shaft of 6 into a shaft of 2, and you turn a very difficult fracture into a relatively simple fracture. It also gives you the other side of the tibia that you can hammer against and you can get fixation into. So Michael Kelly and I differ. If it's almost undisplaced on the medial side or posteromedial side, he'll often leave it alone and see if you can catch it all from one side. I can't bother with that, because once that fragment moves and you start fixing, actually everything's difficult. So I would tend to just go straight in posteromedially, fix the easy fracture, get that right. You don't need any screws in the proximal segment, but I tend to put a couple of short screws in just to stop it twisting around. What you want to make sure you do is not overfix the medial side so that you can't fix the lateral side. You always need to be able to chop and change. And that's your standard approach, very simply, curved incision, down to hamstrings, depending on your feelings about hamstrings. You can window either side, you can cut them and repair them, you can cut them and just watch them fly from the distance if they get in the way. Knee surgeons seem very happy to strip them out of the leg. Don't think it's a problem. You can usually get away with windowing it. If you make your incision further around the back, where I tend to go now, actually they're in front of you anyway. And your choice of anterolateral, you can do a midline incision, and this isn't a dead bone sandwich. This is a midline incision, quite long, full thickness flap, so you essentially get down onto the tibia and you peel everything off the tibia, almost subperiosteally, and then you have a full thickness flap on the lateral side, which will actually be very healthy. You can get a lot of exposure. You can go all the way from the tibial tubicum all the way around the tibial head, exposing that very nicely. It makes knee replacement slightly easier because you're going through the same approach, but I don't worry about knee replacements. That's not my problem. I don't personally like that, because I think you are stripping a lot more than you have to, just to do the operation. Hockey stick, as I said, some people do it, some people swear by it. I think it's a really bad approach. Really difficult to do well, and if there's a complication later on, everything is more difficult. Percutaneous fixation, or not percutaneous, but MIS, open approach, joint open approach for the shaft. You don't have to connect the dots. I think if you've got a complex pattern fracture or an extended fracture which goes further down the tibia, that's very, very useful. You don't really want to expose the whole leg top to bottom. But for your standard, very proximal plateaus where you're looking at 2 or 3 hole plates, I would generally just join the dots because they're not that big. Short oblique, again, very popular. You go just north of the joint, obliquely down towards tibial tubercle. They can raise a full thickness flap there, you're straight on to everything you need to see, and actually you can do most things through it. And then you just have to stab down lower wherever you get to your screws. My personal preference tends to be a lazy S, so I tend to go up the middle of the anterior compartment, curve it slightly back around the level of the joints, and then straighten up the fascial ladder. The advantage of that is it gets you to the front of the plateau and the back of the plateau and the head. So really happy soft tissue approach. It's extensile, so if you're fixing a femur as well, you can do it all in one go. Not have a problem with it, and it leaves plenty of room on the medial side to make a fresh, pristine approach many years down the line to the medial placement through. And sitting down. Acute wound problems are the big issue with plateaus, depending on the energy. It doesn't matter what fracture you're talking about, upper limb or lower limb. The higher the energy going into the bone, the more soft tissue damage it's going to be. It's not unusual to see them looking like that. In that case, you're going to wait, leave it alone, it's absolutely fine. I don't think spanning external fixator has a role to play. I've never seen one actually improve the fracture position. All it does is give you dirty, horrible pins, probably where you want to fix the plateau at a later date. And if you do have to start waiting until 2 weeks, 3 weeks to fix this, you've definitely got infected pin sites. So we intend now, personally, to stay away from spanning external fixation. You can put them into the Richard splint, leave them on bed rest. You can keep on the soft tissue very easily. Or as I said, you go in, the posteromedial bit tends to be easy. The posteromedial bit tends to not have a skin issue. You can go in very early on and actually fix the posteromedial piece. You don't have to do all of the orifice in one go. You can do part now, part in 2 weeks. If you fix the posteromedially, the knee will be reduced, the height will be restored, and everything will be happy. And at some point in the future, you come in and sort of have a chapter 2. If you don't, that's what you tend to be looking at. Nice, shiny metalwork on the ward. Doesn't end well. And that's what we're talking about with the full thickness flaps. Skin, fat, deep fascia, and anterior compartment muscle. All in one go, all in a straight line. And then peel it back. The reason I like to go up to the ITB is if you make a little nick in the ITB just above the femoral condyle and then dissect down, you can dissect the ITB off the capsule so you can get a nice full thickness flap exposure and still leave the entire knee capsule intact, which then allows you to do a submeniscal arthrotomy. And the way I do that is I just poke the knife in sideways until it goes in, split. The more depressed the lateral plateau is, the higher the chance of peripheral meniscal injury. Not unusual, I find the meniscus stuck right down in the fracture. So if the plateau's laying wide open, and the plateau's depressing all the way down, more often than not, you're going to find the entire lateral meniscus stuck in there. So you get in there, you do your submeniscal arthrotomy without meniscus, fish the meniscus out and repair it. There we go. So Tim's operative sequence is the same as mine. Fix it posteromedially, turn a complex bi-column fracture into a simple single column fracture. Because the medial side tends to be the easier one. But look at your CTs beforehand. You might look at the CT and go, that lateral plateau is fixed, that just needs a little buttress. We'll sort that out at the beginning, and that posterior piece is really difficult. So we'll do the lateral side first, sew up, flip the patient over, go back and sort out the posterior. Like most fractures, if you've got a complex half and an easy half, start with the easy half, and that will give you a read and stability for your complex half. And you don't need anything fancy there. I do use a locking plate at the back a lot, but not because it's a locking plate, but because it's already pre-contoured or slightly under-contoured and quite stiff. I quite like it. The 3.5 DCPs that we have here aren't great for that because they're quite bulky. But you don't need an expensive plate at the back. It does just need buttressing forwards. And then once you fix the back, you make your lateral approach. That is fairly straightforward. You just go in, you find the split, you open the split, you fish out all the bits and pieces, elevate the joints. And when you elevate the joints, the reason we don't use bone graft here, I don't think anyone should need to use bone graft, is when you peel open the door on that lateral plateau fracture, you'll see a thick line in the capsular bone where the impaction's happened. And most people really want to get an osteotome into that impaction line and lift it up, because you want to lift up the bone that's just been depressed. That's absolutely fine, but if you do that, there's nothing to fix. You've got 3 or 4 millimeters of bone between your osteotome and the osteotomal surface. So that's why you end up bone grafting, is because you can't really fix it in a happy way. when you elevate that lateral plateau, you get the biggest osteotome you can get in. I do a vertical cut at the front of the fracture, I do a vertical cut at the back of the fracture, and then I go as deep as I possibly can into the proximal tibial abscess, and then lift up the entire plateau. So instead of your defect being kind of here, and then needing to be grafted, what you find is your defect is actually down here. It is completely splintered by your plate, and you're lifting up a huge piece of bone, which can then happily accept your rapid screws through it. And the type of plate you choose doesn't really matter. All the companies are about the same. The key is the anatomic pre-contoured periarticular locking plates, the proximal tibia, do not buttress, annoyingly, and they do not squeeze the fracture across. So one of the biggest mistakes made with plateau fixation, or any fixation with an articular locking plate, is people assume that you put the plate on and it will just make it look the right shape, but it won't. Locked plates will hold it where you've left it, but you've actually got to get it there first. So in this case, Tim likes to put a couple of 3.5 screws all the way across to squeeze, to narrow the width of the plateau, because that is probably the biggest indicator of late failure. If you leave that plateau wide, they don't do well, and they don't do well in the replacement either. So you've got to squeeze it down first. Whether you use screws first, whether you use a big clamp, doesn't really matter. You've got to narrow it and then put your locking plate on with that raft of subchondral screws. And if you've taken up a huge chunk of bone with it, you're not putting those screws just underneath the thin shell of bone, you're putting them through a huge chunk of bone that you just elevated. There we go, same again. Quite a long medial plate, because that's what it needed. And needed the short lateral plates, that's what it got. Personally, I probably would have nailed that and then fixed the lateral plateau on top of the nail, but each their own. So single incisions, why aren't they good? Single incisions are bad if you make an FM sandwich, but single incision, i.e. single column plating, is bad because of that reason. Hands up who hasn't been involved in fixation of a plateau. Good, everyone's done it. How long are the proximal screws? 90 mil, 100 mil, something like that. They're long, long screws. So 100 millimeters away from your plate is where your defect is if you just elevate it from lateral side. So you've got the whole knee hanging on the end of a 100 millimeter long 3.5 millimeter screw. And it doesn't work very well because, look at that. Bicondylar injury, someone's gone, ooh, that's pretty straightforward. That joint doesn't look too bad. I just put a plate on the joint and then I just lollipop it round like I would for a wrist fracture. The amount of force on those screws is causing them to bend at the top, and it's still in massive variance, and that's going to catastrophically fail. It would have been so easy just to catch that posterior piece at the beginning and straighten it up. I think the reason people don't is they're scared of going around the back of the knee, but you're not really going around the back of the knee. So we'll talk a bit about actually going around the back of the knee in a bit, which is remarkably easy, and don't be scared of it. And that's the reason why, this is another reason I started him to talk to build examinations on it. That's your standard kind of raft of screws from your lateral column plate, so your standard antilateral plating. And that is where your posteromedial fracture sits. So even if you manage to hold it all, and you think you hold it all, what you've never actually got hold of is the most important part of the fracture. And if anything at the back is still depressed, they start to get a lot of instability type symptoms. Because as you bend your knee, as you get the femoral roll back, the femur starts to contact that piece of the back that's still depressed, it drops in and the knee gives way, they hate it. Actually, one of the reasons Confeng allowed it is classification, because he spent a lot of his time revising posterolateral corners that haven't, or posterolateral tibial plateaus that haven't been fixed, presented with ACL path instability. And they're very rich in Chinese, so it's even better for you. So that's exactly what happens if you don't fix a bi-column fracture, by bi-column plating. Percutaneous, this is the Schatzker 3s. They are vanishingly rare, in my experience, when you look through the CT scan. But even some of the SHATSCA2s we look at the CT are predominantly just a depression with a tiny little split. And you're looking at it and you look at the patient and think, I don't really want to go in, open up this lateral wall with oxytocin, take your whole knee apart just to punch that piece up. I think it's quite a big exposure for this patient. They don't really need it. You can almost manage this optically, but I kind of make it better. This is a group we talk about percutaneously, and this is the way to do it, and this is the way most people tend to do it. Although I would reverse the punch. Under eye, there's a little cut. Take out a window of cortex. A lot of people will actually, with a drill and oxytocin, make a piece of cortex about 15 mil by 15 mil. And then rather than remove that, you actually punch it in. So rather than the end of the punch going into the bone, what you've got is a flipped bit of cortex acting as a shovel. And under eye, you just punch, 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 and watch that plateau. So can everyone see the fracture on the lateral view here? Everyone convinced that is the joint surface? Good. Watch that joint surface. There you go. But for a lateral plateau, these are Tim's slides, and I haven't got any time to done them in ages. I would tend to make the window on the medial tibial cortex. Much, much easier, because otherwise you're under the lateral plateau and you're trying to punch almost vertically up. It's really difficult to make it in the right place. You could easily make that window over here. Much, much easier. And a good way of working out where you need to be is just use a DHS guide wire or something. Because you can just fire that all the way in under eye from where you want to start to the fracture. Some people even go as far as actually just using an ACL set of reamers, so you put the beef pin in from the medial tibia, on my eye, underneath the fracture. You get an ACL reamer, whatever size you want, whatever size looks about right, about 10 mil. Go through the cortex and then just hit it with a hammer and actually use the reamer as a punch. And it'll follow that wire exactly to the fracture line. We'll sometimes punch the wire through the femur, but it works really, really well. You can do it under eye, you can do it arthroscopically, but for those fractures, particularly those posterolateral corner fractures that you don't think really warrant quite an extensive approach and difficult fixation in the certain population, just banging up percutaneously and then putting rapid screws under it. Works really, really well. So more roof, maybe still lots to talk about. There's a lot there. This one essentially goes, if you've got a bicondylar fracture, you do better if you have bicondylar planting. It's good that people do research like this to prove the obvious, but otherwise it's not proved, and people will still say you can fix a bicolumn injury with a single lateral plate. People do much, much better with two plates if it's two fractures. And they also do better if the medial piece or the posterior piece is a big, big chunk. Kind of goes without saying, really. And that's what we're looking at is that sort of big piece on the posteromedial side. These were, again, kind of saying if there's a posterior fracture and you don't fix the posterior fracture with a posterior buttress plate, they do bad. And again, for a long time, certainly in my training, you didn't really fix the back of the knee very often. And the patients did really badly because as that femur rolls back in flexion, if the back of the tibia is missing or sloped down, the femur will just drop into it all the time. The big bit outcomes, a lot of people say, well, what's the risk of knee replacement? And some of my colleagues say, oh no, it's no increased risk. There is a massive increased risk of needing a knee replacement after a plateau fracture. Of all of the knee replacements, a very, 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 very small percentage have had a previous plateau fracture, but there's a lot of arthritis out there. This is probably one of the only papers that's looked at in detail. Wasserstein? Probably how you pronounce it. From Ontario, they looked back retrospectively and found that at 10 years, nearly 7.5% of plateau fractures have been converted to knee replacement. Now, they don't really go into details as to why. There is going to be a group of those patients who are heading towards knee replacement already. We've all seen plateau fractures in people who've got arthritic knees. But it is age matched 5.3 times the background rate. So you're 5 times more likely to require a knee replacement after a plateau fracture at 10 years than if you now have a plateau fracture. So it's definitely an independent risk factor for needing arthroplasty. Not too bad. We might skip over the cases. We'll come back to them in a bit if we get time. One thing I want to show you is what Mike calls the FCR approach to the back of the knee. This is his, like I said this morning, I haven't even looked at it yet, but we both do the same. So no one would be in disagreement. If that was a wrist, you'd fix it. If that was a posterior malleolus, you'd fix it. If that's the back of the knee, people go, oh, it's the back of the knee, or don't fancy that. It'll be all right if I leave it alone, and trust me, it won't be. They will continue to shear off, they'll continue to have instability, they'll continue to have back problems, and actually their knee replacement becomes more difficult because their tibia isn't the right shape. So you're then trying to do a primary arthroplasty in someone who's 55 years old, who hasn't got the right tibial slope, hasn't got the right anatomical proximal tibia, so you're starting to go into slightly more complex arthroplasty for their primary. The best thing to do is get it right the first time. So there's one thing I think. Will this work? Yes. So this is actually the injured knee. You can see it's quite a big piece down the back, that spike there, and more importantly, the tilt of that fragment. It really does need going in the back and actually doing properly. There's no way you're going to get that from there. You're going to look down the axials and work out where it is. And where the apex is. The apex is always going to dictate where your plate is. I mean, this is standard AO buttress plating. There we go. So actually that apex coming in is reasonably posterolateral. So that isn't something you're just going to sneak down the posterior wall of the tibia and see straight away. It's quite a long around the back of the knee, but at the same time it's really important. And I don't think it's a particularly difficult part of the knee approach. I've done one true posterior approach to the knee as a consultant for this type of fracture, and I utterly regret it. I spent about 2.5 hours doing the approach. I had a wound about that long, and I could see that much of the tibia. I could reduce the fracture, and I couldn't fix it. There's a huge wound in the back of the knee. I've sweat dripping off me. There's neurovascular bundles everywhere, and I've achieved nothing. But they do need fixing. So I tend to do them prone. Mike tends to do them prone. It's much easier to do them prone, but it does limit what you can do. You can only fix the back of the knee. I'm sure you could probably do an antilateral plating prone, but that would confuse you way too much. So tend to fix the back, sew them up, flip them over, fix the front. And what you can see, the dotted lines there is the medial head of gastroc. So your incision is right in the middle of the medial head of gastroc. You don't go beyond the flexor crease, and you can go pretty much as far down as you want. So a decent sized cuts. You don't really need the transverse limb of the true posterior approach, but you can add it if you're struggling. You through the fat, again, full thickness flap straight down, you're onto the gastroc, and you pull the gastroc out of the way. There is nothing important between the skin and gastroc, and there is nothing important straight under the medial side of gastroc. So you just go through the fascia, you reach around, grab hold of the gastroc and pull it. And then it shows you a bit of sleius and a bit of hypotheus. And then it is just like the FCR approach to the wrist. You pull everything in that direction, suddenly you're left with PQ. What you do with PQ, you make your L-shaped cut and peel off. Same hypotheus, so you go across the back of the plateau, don't cut PCL. Although, as I found out, it makes the approach even easier. Straight across the proximal end of hypotheus and straight down the medial edge, on literally cutting straight onto bone. And then with a Bristow, you just do a subperiosteal reflection, and as everything comes up, the neurovascular bundle is protected. The neurovascular bundle is now protected by popliteals, and you can go all the way around very, very easily. Here we go, so there's popliteus, there's your cutting popliteus, there's moving out of the way, there's back of the tibia. The one thing you're at risk of doing here that's very, very bad is advancing the anterior tibial artery. Very bad indeed. Don't do it. So in order to avoid that, when you put your Homan across the back of the knee, it goes into the proximal tibial joint. So I tell you something a life like X-ray monotractor going in. Sharp Homan into the proximal tibial joint, hammer it in, elevate, and just keep releasing on the medial side. And you can release pretty much as far down as you want medial, and just let it flop open. If gastroc really tight, you can just bend the knee a little bit. That works 99% of the time. If it doesn't, you can just cut the middle head of gastroc off. I'm an ankle surgeon. The middle head of gastroc is the root of all evils, and no one's ever worried about cutting it. So if you need to reflect the middle head of gastroc off, you can. You don't generally need to, and you can see all the way round, all the way to the proximal tibial joint at the back from the medial side. Okay, it's a much safer way to get in. It's really easy. It gives you great exposure. There you go, there's a true AP in the knee. And you can see how far around that plate is. That is properly on the back of the tibia. That's not on the medial cord, that's right on the back. And Mike and I both also got cases where there's a plate right over here, all for the posterior approach. It's such a safe way of doing it. Don't be worried about it. It just takes seeing it once or twice, or doing it as a cadaveric session at the end of this year, and of course, it's like running this. Just to plug it again. It's a really good workhorse approach to the back of the knee. There you go. That's gone in through a posterior approach. Long way around that stuff. It's not difficult. And your protected neurovascular bundle, the only thing you need to worry about is your anterior tibial artery goes through about here. So you don't want to put a retractor in there. So a retractor goes right across the tibial joint and further down if you're going further down, but not in that area. There you go. That's just what I want to say for Mike said this morning. He's actually the one who's got photos of it. Really, really good, useful approach. I recommend you all give it a go. That's how you learn it, Troy. You just give it a go. You tell the boss, you go, at this talk, sounds like going on the back of the knee is really easy. And they're like, are you sure? Yeah, I've got it, don't worry. Before we move on to the rest of the tibia, this is going to be rapid fire, so this is a 2-day course by itself. I'm trying to give you as much of an overview as I can without dumbing it down too much. There's a lot of information. Oh, anyone got any questions on plateaus? No? All simple? All happy to crack on?
The other standard approach is not to the post-lateral side. You do a tibial osteotomy.
Yes, I think the post-lateral approaches, there are a couple, well, there's 3. I personally don't know anyone that uses them. Because you can get that far around the post-lateral side to the medial side, which is safe. I think most people tend to do that.
So is that not one of those, my Achilles, don't ever mention it in the exam?
No, so that I think, although someone writes it up and is doing it Mike's FCR approach, I'm pretty sure Conrad Lau wrote it up. I just want to add his name to something else. But that is a fairly, it's an extended posterior approach. The posterolateral approaches I've only ever done on the cadaveric course, and I didn't really enjoy the one now. So you've got an osteotomy of the lateral ligament. So that is either a tibular head osteotomy, where you rip the tibular head out of the proximal tibial joint and proximal nerve. It seems really destructive and horrible. Or you can do the opposite, which is you just take out the origin of the lateral ligament from the lateral epicondyle of the femur. Just take a huge chunk out, expose the nerve and decompress the nerve, reach into the knee, don't tell any surgeons, cut the anterior root of the meniscus, lateral meniscus off. and then you can spin the knee and you get right around the back of the knee from the lateral side. You can't do much with those approaches other than get a very small rim plate just on the lateral corner, but it might be very useful. And then when you come back to fix it, you just screw your lateral collar back on, and you do an interosseous suture of the anterior root of the lateral meniscus.
The only difference with that, with the FCR twitch and compound is that compound does the horizontal limb.
Yeah.
Like the open half of the type.
The horizontal limb depends really on how fat the patient is. If you can't extend vertically beyond the crease, so if you need to move more skin out of the way, you're just going to have to go sideways across it. But it really doesn't matter.
But I'm right.
Oh, that's it, right.
And your name's on the paper as well.
Awesome. It'll be a seminal paper. Completely different to concrete lab paper. But no, it's a really useful workhorse approach. I said the other approaches I wouldn't worry too much about for your exam. If you find a British surgeon who's done a fibular head osteotomy for a plateau fracture, yeah, you found the one. Concrete lab does do a true posterolateral approach to the knee. So he just does almost the posteromedial, but on the posterolateral side, dissects out the neurovascular bundle, moves it out of the way, fixes it. In his own statement, and I've met him and I've talked to him about this, he's repaired quite a lot of peroneal nerves and quite a lot of arteries. In one patient, he went in, did the approach, cut the nerve, cut the artery, repaired them both. Plated it, then he had problems with the plate, so a couple of years later he went back in, accidentally cut the nerve and the artery again, repaired them again, and took the plate out. So in the hands of an obscenely gifted surgeon, if he can't do it, I'm not even going to try. So on to penile fractures, other end of the tibia. Essentially, it's the same sort of thing. This is the penile fracture talk from BOFAS, hence the slide that I gave last year, which is their fairly standard principles course. Anyone coming up to the exam, I'd really recommend the BOFAS principles course. It's good as a junior because it kind of gives you a lot of sort of basic understanding of ankle surgery. But coming up to the exam, really, really good, because it just cements all of that complex foot and ankle work in a couple of days. And I think really explains a lot of things in ways if you're not a foot and ankle surgeon, can really help the exam. I'm not plugging courses I teach on or get paid for, but they just happen to be good courses, and I happen to be faculty on them. I get paid a bit. So again, what the fracture's like, blah, 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 classification management outcomes. Same old, same old. Penile fracture is slightly different to plateau. In fact, some plateaus have massive soft tissue injuries. Almost all penile fractures are big soft tissue injuries that happen to have an exploded bone. And they are really high energy. So just like an axe splitting wood, the talus, anyone's operated me, you know how hard the talus is. Given enough force, there's only going to be one loser between the distal tibia and the talus. It's always going to be the tibia. And the talus will just keep on going. Plain X-ray is always where you start, and CT. If you are going to span it, repeat the X-rays, repeat the CT after it's been spanned. If you are going to put an X-fix on, that is how much traction you need to on the 5mm denikin. So this is actually the slide that they've used in BOFAS principles course for about 6-7 years now. I thought of it for the first time last year. This is my X-ray, it's a first-year registrar that someone has sold and put in the BOFAS talk. But it's always good to have your work recognised. So this is quite an old paper. But actually 96 isn't that long. Well, no, 96 is what, 23 years ago. So it's quite an old paper now, and now I feel quite old, saying that surprisingly, CTs were really useful in penile fractures. I can't imagine trying to fix a penile fracture without CT. That would be miserable. There are probably more classifications of penile fractures than any other individual fracture I know of. None of them are good. None of them are particularly reproducible, and none of them really help. But the commonest ones are the AA classification. Essentially, I'd limit it to type A, B, or C. The Rudin-Algau classification, which I don't really understand and don't really ever use. And I think most useful, but most difficult in terms of Claire's paper, Thomas classification. So the Rudin-Algau, 1, 2, 3. All right, bad, very bad. That's about it. It's like, is it a simple pattern fracture that's actually the keeping piece? It's a 1. As one of these is moved, it's a 2. If it actually shattered, it's a 3. It's not the most useful of classification systems. Claire's paper, however, which is actually her MD, she spent a lot of time on this. As I mentioned, I would try and read it. I would try and read it a few times because it does take it to get your head around. I still can't get my head around the whole paper. But what I can get my head around is the way she talks about the fracture patterns. So is the main fracture line coronal or is it sagittal? So if it's mainly coronal, you're probably going to put an anterior plate, or you want a lot of AP fixation. If it's predominantly sagittal, you might want a lot of medial lateral fixation. That's kind of what you're getting from that. But I think most usefully is her talk about the individual fragments or the common fragments that you see. Your anterolateral piece, your medial piece, your posterior piece, your dipunch piece. But for me, the biggest learning point in this paper is what she calls functional diastasis. So that shampoo fragment that comes off, that you think, oh, I've been in this pilon for 2 hours, I finally fixed it, I'm awesome looking at x-rays. And then you look at the x-ray 6 weeks later, it looks awful. And it's because they've got that little piece off, that anterolateral piece, that functional diastasis piece, that's still got the AOTFL attached to it. So if you fix everything else, particularly if you're a medial plate, or you think it's a medial plate, and you haven't fixed that fragment, you've actually got a syndesmotic injury. So when the talus goes up, it will tend to, in these pattern fractures with that shackle fragment on, the talus tend to drive up in between the tibia and the fibula. So you've ripped apart all the ligaments, all with bone fragments on. If you don't reattach those ligaments, you've essentially not fixed a syndesmotic injury. So no matter how good the tibia reconstruction is, the ankle reconstruction is bad. So always look out for that fragment. Even if it's really small, you might just need to ligament repair. So that's probably my take-home message from Claire's paper is those are the common pieces. So how you're going to fix them, and the functional diastasis. And the treatment is exactly the same for everything else. This is a high energy injury. I would manage this patient weight test principles. Assuming it is an isolated, closed, neuropathic impact injury, I would do the following: analgesia, stentage, imaging. And then I don't think you'd be able to say anything with the pilon fracture other than spanning, scanning, panic. I think there is definitely a role for hyperacute fixation for 24 hours. I think that should be limited to people who do a lot of them and get the results with them. I don't think it's for the jobbing orthopedic surgeon to be jumping in and doing a hyperacute pilon fracture. Your approach is much more limited. You can't go down in front, you have to go very laterally, lateral approach. You can also go around the back. But I think exam-wise, for most of you, unless you've got a real interest in fixing pilon fractures, it's spanning, scanning, panic. And this is the common frame that's taught. And this is the frame I used to see a lot of when I first started it, and I absolutely hate it. It's lazy, what it is. You put an A-frame on it because you can't be bothered to extend the bar to that length. Someone will get the longest bar on the X-fix set and go, well, that's as long as it can go, so I'll just put my pins in front of the tibia here. People don't like pins in front of the tibia, they don't like them long term, they leave horrible scars, they get infected. But most problematic for me is almost every time those 2 or 3 anterior pins are exactly where I want my plate to end. That's how long I want my plate to be. So I've got 2 options. I can either leave my plate at the right length, and I've now got 2 or 3 pin sites, which probably won't ever fill in, right at the end of my plate, causing a stretch line. Or I can span past those pins, and I can cover those dirty, horrible, infected pin sites with my pristine, shiny metalwork, which is now also infected. So there's no good option. So if you are going to put a frame on, I prefer a quadrilateral frame. I'll have Pallister, who has written it up in Injury, I think. And that's a transfixion pin, anterior tibial head at the top, transfixion pin in the calf, pulling it bloody hard and putting it back up. The advantage of that is also you can leave on during your entire pilon fixation. It doesn't get in the way. And your pin sites are far enough away that they'll never interfere with the pilon fixation. But you do need to piggyback 2 bars together, it's not difficult. Can't remember when that was published. Probably about 2006, something like that, Injury. Tip sort of thing, but very, very useful. He talks about a few different types of emergency external fixation. And your overall management, God, this is getting boring talking about pilons and plateaus together, they're the same injury, they're just upside down. It's a stage management. You're going to span it, you're going to scan it, you're going to plan it, you're going to wait till the soft tissue settles down, and you are going to wait till the soft tissue settles down. It's not a case of, oh, it's been 5 days, let's just crack on. If the soft tissue is bad, the soft tissue is bad. The worst outcome from pilon fracture is infected fixation and failed skin. The fact that you can't reduce it, you can't fix it very well, and they end up very early on with an ankle fusion, that is not a problem. If the skin's okay, it's not infected. So if you have to wait 6 weeks, have to wait 9 weeks, well, you can wait 9 weeks. And you're going to limit how good your fixation can be at that stage, because the downside better than staying at left with some water. Traditionally, and I think still the exam, your approach is going to be predominantly guided by CT. You want to come down directly onto the main fracture line, so that you can open it up, so you can do a full thickness flap. And by full thickness, I mean really full thickness. Skin, fat, fracture, periosteum, fracture. So everything in one go, all the way down to the other side of the leg. Open it up, fix it, close up. And in the questions, I think I'd agree with it, is you want to fix the articular surface first, and just like the plateau, these locking plates are not going to do the job for you. They're going to splint what you've managed to do. So you might have to clamp it before you fix it. You might need to put some temporary wires in. You might need to put some periarticular screws in first to squeeze down those fracture planes, and then bridge out the plate. But the most important thing with articular reconstruction like this, joint first, reattach the joint to the tibia afterwards. And columns. Just like Hongfeng Lao has recently-ish been talking about the plateau, everyone's been talking about pilon columns for a long time. A bit like spine, you're just looking at the front, mainly, so you've got medial, central, and lateral. You have to fix either the medial and the lateral, or the central. You can't just fix the medial side, because just like the plateau, it's going to drift off into balance. I think as we look more around the back of the ankle with ankle fractures, same happens now in pilon fractures. So we're fixing more pilon fractures from the back as well, appreciating that big posterior piece that Claire talked about years ago there when it was. So how are you going to approach it? This, traditionally, you're going to CT guided approach, you're going to come straight into the fracture plane to clear out the fragments, elevate the joints, squeeze it down, and then fix it perfectly that way. And there's nothing wrong with that. That is absolutely fine. However, I would prefer myself to come in anterolaterally to this, because actually I want my screws to go in that direction. I want my screws to be attached to the plate. So I would tend to come in anterolaterally and open that window up, fish those pieces out, close it, and then fix it. It doesn't really matter. But you have to appreciate the CT where you're getting into the fracture. So it might be the same place as your surgical incision, our traditional teaching, directly onto the fracture, directly in. Or it can just be, well, I know my approach is going to be here, that's where I like to make my approach. But my window in the bone is going to be over there, and I'm going to go fish it out. And that's a sort of minimally invasive type thing that people talk about. And whether it's an X-fix holding it out, or whether it's a plate, it doesn't really matter. Essentially, you're going to open it up, you're going to open the joint up, you're going to stabilise the joint, make the joint look good, and reattach the joint onto the axis somehow. Now, whether that's plate stood up, whether that's an X-fix, whether it's laid right over the plate, doesn't really matter. Joint, reattach the joint onto the bone. And where do your plates go? I think the people that say always use an anterolateral plate are wrong, although I always use an anterolateral plate. I think the people that say always use a medial plate are wrong. I think medial plates are very, very tricky to get right. There are a few people in this region who are very good at them, and I would say learn from them, but they're very, very difficult to work well with because people don't like them, as in patients. The skin's very awkward around that, and if you make an open approach, it will break down. So actually, if you're going to do a medial plate, you're going to tend to do a medial open, and you can't do a lot with joints. Essentially, the plate needs to be where the plate needs to be. This is a very, very straightforward pilon fracture. But it kind of highlights the fact that this has drifted off over into valgus. So you need to push it back from the lateral side. And you've got two options with that. You can either fix the fibula first to bring that length down to push it over out of valgus and then fix the middle column. or you can just go straight in and fix the central foot. But your anterolateral plates, again, will tend to push it over to the medial side. That's the commonest pattern of injury. If you have the opposite and the distal tibia has gone medially, you go and push it from the medial side. So you push it from the medial side. Most of us have moved away across all fractures, really, away from jumping straight to articular locking plates and more towards basic plating techniques, AO, and buttressing things. There's a lot of buttressing, like so that little third tumor there is buttressing, because it wants to get another way. And then that LCP is just strutting it out and acting as a bridging concept. The outcomes of P1 fractures are massively, massively variable. There are numerous papers out there, and none of them really give you the answer. The outcomes can be good from ortho fractures, and it can be bad from simple fractures, and that's anecdotal and everything else, but the papers kind of agree. The infection rate is ridiculously high in the literature, and I cannot explain why. As it says here, up to 50% infection rate in some series. They're quite old, as we said. But even in more modern ones, you're looking at 20-25% infection rate. And that's way too high. So I think a lot of that is down to surgeon experience and surgeon choice of type of approach. I think people tend to go medial because it's easy, because they're subcutaneous. I think you've got a higher infection rate, a higher complication rate. People don't like to go anterolateral to the ankle, same they don't like to go posterior to the knee, because there are important structures in the way. A lot of this was used, people say, oh, percutaneous fixation and framing is the best way forward, or percutaneous fixation and spanning on lateral exit is the best way forward. But again, just like the knee, it was the wrong choice of technique over the actual technique itself that was the problem. Staged ORIF now seems to be very, very good. So most of the papers, as you go through, the infection rate comes down, satisfaction rate goes up as people have moved away from this is an injury, just going with a basic set, fix it 50 years ago, through to span it, scan it, plan it. Everything seems to work out better. But the outcomes really depend on how bad injury is. So how much energy has gone into it. I fixed one this morning that was pretty straightforward. He'll do absolutely fine. Fixed one a couple of months ago, he'll do awfully. He fell 30 feet, I think. And his medial tibial diaphysis was stuck in his lateral calcaneal wall. That's not going well. So the injury itself is what dictates the outcome, along with patient factors. Unfortunately, P1 fractures are often attached to not exactly type A hosts. They're either up a ladder that they shouldn't be, or coming out a window that they shouldn't be coming out of or going into. Or they're buildings that are up scaffolding, they're up ladders, they tend to smoke, so your infection rate's going to be high and your immunity rate's going to be higher. Tends to also be a working age male injury. So the problems they have are bigger because they tend to smoke the workers, and they can't go back to that because they've got them. The one thing that shouldn't affect patient outcome is surgeon factors. If you're not good at them, you shouldn't be doing them. Simple as that. I don't do total hip replacements. I don't do total knee replacements because I'm bad at them. Trauma, however, seems to be different. Most people will just have a go. Now, I could probably do a hip replacement better than a standard DGH arthroplasty surgeon who never does a P1 fracture and fixes a P1. So it's about choosing your winners and getting them to the right person. And that is the big exam answer across the board. All complex injuries, all complex problems need to be treated by the right person in the right hospital. If that isn't you, that's absolutely fine. Just get it to the right person, but do the emergency management first. I think P1 fractures are so varied, you can't really teach a lot about them, you just have to get in and do them. It's just a case of opening the window, reducing the joint, putting it all back together and strutting it out. But more than probably any other injury in the body, it is about respecting the soft tissues, and that's waiting for soft tissues to allow you to do it, or doing it hyperacutely if you're experienced in that, and managing those soft tissues well when you do the surgical approach. You can't just go and strip the whole distal tibia. Now, we know there's a dead bone sandwich of the proximal tibia through a single approach, same with the distal tibia. You can do 2 or 3 approaches very easily with the distal tibia. You can do anterolateral, posterolateral, and direct medial all together. Very, very safe as long as you do them well. as this is the bone, fell 30 feet off some scaffolding. So that piece of bone there, which is embedded in his calcaneum, and has to be pulled out with a pair of pliers, came from there. So like most injuries, don't look at what the injury is now, think about what the injury was when it happened. His talus was a long way away from where it was meant to be. No, can't play, never mind. CT looks bad. Anyone want to guess at how you're going to fix that? How you know this? Okay, let's ignore the fact this is a high energy injury. You take less principles, blah blah blah, and we're going to start a dynamic plan. How are people actually going to definitively fix this? On front row, pre-exam guys.
Well, I had a look at CT scan to get.
CT scan looks very bad.
Looks really bad. I mean, you're gonna plan your approaches based on where the main fragments are. So if you do have any main fragments, I mean, if that.
So the main fragment is in his calcaneum. There isn't a hell of a lot of rest of the tibia.
Is there a predominant sagittal arrangement? It's everywhere.
Well, then I suppose
His tibia looks like a bag of rice.
you can span X fix it and just hold everything up to length while it heals. If there is nothing to plate, I mean, it's obviously not and it's closed, right?
Yeah, this is actually open, but believe it or not.
Yeah.
It's only a little bit open. We managed it as if it was a closed fracture almost.
I mean, if there is nothing to get metalwork to hold on to, then it'll be an indication for a frame.
What is the outcome of this fracture going to be?
Or,
Yeah. What is he going to have at some point? Yeah. To be pragmatic about it, this guy is going to have an arthritis. Can you primarily fuse that?
No.
No. I mean, you probably could. And you'd have to use a nail, or use a frame. But there isn't a tibial surface to prepare. I mean, there's bits and pieces, but there's nothing solid there. So essentially what you're waiting for here is this to go up, aligned, and see what happens, and end up with a fusion. Now you can do that non-optively, well, with cast, very bad. You can do it with spanning external fixation. You can do limited internal fixation, just trying to snuggle those pieces roughly into the right place and span it with the frame. Or you can plate it. I mean, it doesn't matter, but you've always got to know or be prepared that this isn't going to end well. So the patient needs to know that on day one. There we go. His X-ray looks lovely. He's very happy with them. I keep reiterating to him, although he doesn't speak much English, that his ankle is toast. The key is pulling that piece back out of his calcaneum and screwing it back into his little shaft. Because that's going to be really important for him in the long run, because that's actually going to be something he's going to need after he fuses ankle. But I've limited my fixation because there's no point going to town on this. There's no point having a lateral plate and a medial plate when I've stuffed all this out. This isn't going to end well. And I want to simplify the fusion later on. And all I'll need to do is take out a couple of screws and put a couple of bigger screws back in.
How did you get these fractures out?
So it's just standard. So I did a lateral approach and lateral approach to the peneus tertius. And it's easy to just find it because it's stripped all the way down. So you just follow the hole and you found the end, grab the pair of cloths and pull the hole. I mean, people on
through his heel there. That piece has gone through his heel as well.
Yeah, no, actually, it's different gone through his heel. So remember, that talus has been half of his leg, but his fibula's not broken. So if the talus and the calcaneum with the rest of the foot go that far up and the fibula is still there, the fibula is going to come out. But we just watched it stitched up and it all healed up. Even the plastic surgeons agreed. So tibial fractures are really difficult to talk through because there are so many different papers saying so many different things about them. And essentially, you can do whatever you like to tibial fractures, provided you do it well and you respect soft tissues. Like most trauma, people can stand here lecturing you for hours and days, but you just try to do them. And then it becomes quite simple. And then on to the most important fracture in the world, tibial shaft fractures.
So I don't know if you want to stop there for 10 minutes, because there is coffee upstairs. If people want to just
Yeah, start there in 10 minutes. Coffee. And anything else might get rid of. Half an hour. And then get over all my order. Running by strike. So if you run by strike, there's like one tweak you might make one word. And it's got it saying this. So you do day in hotel day of theory, which is essentially day of cases. Not a lot about activation, it's just case. Then we call it. Then we wake up early, bus over, so yeah, I think it's the last Thursday. November. First by 3 years.
We've had.
It's a really good course. We might ride it and the consultants have to be really good.
And you're going to do it just for registrars?
Yeah, so the first year ran it slow with everyone, and it was a bit of a mixed bag, and it didn't work that well as well. Yeah. And then this year, it's about just consultants. Yeah. Annoyingly, it's kind of a master's level course. It's the level I expect registrars to be at. Yeah. But it's not the level that consultants are at.
No, because you probably will get a lot of consultants who are doing.
And the weird thing is, like, we discussed lots of complex cases and really difficult ones. And that's really changed every consultant.
So basically, I couldn't decide if to buy that or new.
Yeah. Because
You just take off the Mac store and say, how do you do that?
Yeah, I know.
but it's actually what they offer, what they are to defense. About to do something. Because we just spend so I get it. And then we thought actually probably next year, rather than kind of piggyback it, registrars, senior registrars and fellows 1 year, consultants, kind of alternate. Because otherwise you end up saturating the market very quickly because you've done all the regional consultants. Well, I don't know, people came out from Scotland, Ireland, some of Europe. So it's a really good course.
Peons?
Yes.
When do you use fragment-specific fixation?
Everyone.
So with that one, for example, there was a big medial mouthpiece which you didn't fully, and a big posterior chunk.
I mean, that one's polishing a turd.
Absolutely, yeah.
There's no point.
It's so scary.
I know you're thinking to access, but why?
I want it to heal, and the problem with next fix is you're just going to hold it forever.
Well, this is all you're doing with that thing, the alignment, to allow you to know.
Yeah, he's been walking since week 2.
Yeah, but that's because he's a crazy part of
No, it's not problem. But no, it's fun. I just went walking from week 2 to sausages out there.
Okay.
Because, I mean, one of my big electrics is because I have no idea how long that's going to take to go up. 6 months, 9 months maybe. With the plate on it, can wait as long as it needs to. Okay, the plate might fail, that's not an issue. But with an X-Fix on, he's got to be in that X-Fix until I'm certain that it's healed.
Yeah.
And then I go on to do his fusion.
Well, you could
He's
have
had
actually
experience.
cars when he's largely healed.
But he's still been afraid for months and months and months. It's fucking miserable. And then when it comes to his fusion, he's had fine wires in his talus for months. And his talus hasn't looked just right, so his talus will have a chronic infection.
Yeah.
And then I'm going to try and get ankle fuse.
Yeah, that's good. You got much better control of the alignment, don't you?
With his brain.
In terms of the
AFT, that fracture. bit of joint surface doesn't exist. I just took pieces of bone and fitted the holes I had. And there's no cartilage.
And hit it. Yeah.
That's
what we would say.
But in your first one,
Yeah.
the only thing a frame allows you to do is tweak your alignment. You've done it.
Yeah, drink. As long as it holds and doesn't do something crazy.
I mean, I wouldn't be in a frame for 6 months. Admittedly, I just top out someone's taking my frame on last week to be in a frame for at least a year. But yeah, that's not my fault. But when you can avoid a frame, I avoid a frame.
Yeah.
That's my view. There are lots of people that will tell you the exact opposite.
Yeah.
The open ones, so Jacko's, I know all of these need to be framed. Because we have actually got quite a high effect rate of open ones. So Pete Bates thought that a few years ago. He's a very good frame. He was framed on these and like 50% impact.
Really?
So whatever happens to open pelons, and in fact, the infection rate in closed pelons is realistically in most people's hands probably the best part 10+%. That's in closed fractures.
Yeah.
You know, they are fucking horrible injuries. Put up say I'm trauma surgeon and they are the injury I hate.
Yeah.
I hate pelons. I love Taylor's, I love Cap, I love a midfoot, I love a tibial shaft, plateau, and distal femur, intercapsulated fracture, any of them, I don't think. I do lots of pelons, I just hate them.
But is that
Because
easy?
they are not easy.
And they don't.
And they're not forgiving and they don't do well.
Yeah, regardless of what you do.
If you shattered your articular surface limitator or tibia with your talus, you are not going to do well.
Well, yeah, your good outcome is making them unaffected and getting them.
Yeah, it is literally alignment and weight bearing.
Yeah,
And then whatever happens, happens.
yeah.
You know, I've got one patient, she was an ankle stroke, that's a very grey area.
Yeah, but
Really unlikely it's a part that I've moved up the tail and well. I inherited it for a femoral wound, which I sorted out. And 4 years after she had a femur fracture, I dropped the leg off. They were non-infected, non-union with degenerative. I excited to talk about bone fracture and those different options and she just went, so she had skin healed eventually, lots of wound healing problems. Then had complete collapse of the joint. I was going to fuse her, I couldn't because the whole tibia was dead. So I talked about the various options and she ended up having a off at the age of 32. So a pelon fracture. Close femur.
probably an otherwise relatively healthy.
Yeah, supposed to be better than weight, but
Yeah. Yeah, so it's,
so because of enclosed pelon fracture, she's had an amputation.
no, but I really
Cheers,
do.
mate.
No, thank you very much, Mr. Dennis. That's all right.
We're going to rattle through
Hold on,
it. It's basically tibial shaft, right?
What's that?
No, yeah.
Yeah.
And he got the leg.
it's interesting. Just for the close injuries, you know, I think.
Yeah.
I think it's huge.
We release the and then we attach it to transport systems.
How many soldiers are there out there? I've got all the ones. Yeah, it sounds like I was speaking to Steve, so it sounds like Striker gonna fund it. Yes. So they've already been funded.
All these things tibial fractures. Right, let's make a start on the last part, the nice simple part, the part that there is no argument about. The most important part of the body is the reason it's supported to in the AO classification is tibial shaft. Tibial fractures, you can manage them non-operatively. Apparently. The one thing you can't do is non-weight bear someone. So if you want to manage a tibial fracture non-operatively, they have to be weight bearing. Now, that can be a Sarmiento cast or a boot, it doesn't matter, but there's no point managing a tibial fracture non-operatively. I'm excluding peds from all of this because kids are weird. If you do have a tibial fracture that looks great, looks undisplaced, and there's intact tibula, what position is it going strict into?
There's.
Valgus. It'll do valgus. And it will, if you are to manage an orthodomy, you have to be really, really critical with your seal x-rays. That is the classification you can just about make out. The tibia, the red lines are clearly underneath navel. The green lines, I would also say, are within naval limits. So between the red and the green is where the grey area comes in for how you're going to fix it. You can nail it, you can frame it, you can plate it. You can actually do that to any part of the tibia. I have plated mid-shaft tibial fractures. Heresy, I know. But in some situations, you haven't really got a choice. The last one I did was a stem knee replacement above it. What else are you going to do? But it's about choice of incision for that. If you go into the back of the tibia, it's lovely, it's big, it's flat, it has a big surface to put a big plate on with a lot of muscle covering it, and it doesn't matter, they do well in my stage of two. But what the tibia really is whispering to you all the time is nail. It is a subcutaneous bone. It is nail shaped. It is really easy to do. And it just needs nailing. I know Simon Royston would disagree with me slightly. He has issues with handling the devil's penis, as he calls it. And you can frame them, but just nail it. And the anatomy of the proximal tibia, next slide, shows you where your entry point is. And your entry point is way further back than people think. And the entry point is here. There's actually a little bare area on the tibia when you expose it. And it's almost like we were designed to have the perfect, useless part of the bone that has no function and no structure on it. It just fits the tibial nail in it. Like whoever designed this thought, you know what? A couple million years' time, these people are going to need their tibias nailing. I'm going to make a nice entry point to make it for them. It just sits there. And you can do it a variety of ways. You can do it semi-extended with the superteller technique. You can do it in the teller. Those of you guys who work here know that we tend not to do superteller nailing here. do occasionally. I don't particularly enjoy it. I think there are lots of problems with it I don't realise. And also, if it ain't broke, don't fix it. I've done probably 300 intrapatellar tibial nails. I'm happy with it. I'm an old dog, I'm not learning new tricks. But single nailing in the right hands can work well. But I've never found it as easy as everyone who's a big fan of it says. Intrapatellar nailing is done like this here. Unfortunately, the lines have come off, but that is the bottom of the patella. You do not need to make an enormous incision in someone's leg and open up the whole patella tendon. You make a small cut in the skin over the patella. You pass your guide wire in percutaneously to be in the right spot. You then slide your knife down the guide wire to cut the tendon exactly where you want it to be, so you never fight in the tendon. And then you nail it. Like that. The hole should just be big enough to hold the proctoscope. And that's what it looks like at the end. It's always the top part of your incision which you're really unhappy after the patella nail. So make the top part of your incision longer and the bottom part shorter. Yeah.
What's the least amount of flexion you sort of get away with when you're doing the patella, when you're flexing? Have you got these?
About 100 degrees. So setup wise, which is something we haven't really talked about, traction is a big no-no. So you put them on the tibial nail traction attachment, which we haven't even got here. You can only really get them to about 80 degrees of flexion, maybe 90 if you're lucky. And that is well short of where you need to be to make a good entry point, because your entry point is there. Okay? That is your entry point. It is not here. It is definitely not down here. It is there. And to get that entry point, and more importantly with any nail, whether it's a tibia or a femur or whatever, not just your entry point, but your entry angle. So not where you're going in, but also how you're going in. Because if that goes straight front to back, that's not going to work. It needs to go down as going to be a nice bit. And something that Mike and I learned for the first time about 2.5 years ago from Alex Trompeter is he was talking about the true anatomic axis of the tibia. And actually, as it turns out, if you follow the medullary canal down the tibia, it doesn't end in the middle of the ankle. It ends in the lateral third. So for many years, I was taught middle of the knee to the middle of the ankle. And I taught many people to do many nails, middle of the knee to the middle of the ankle. And Alex Trompeter stood up and he gave us his talk. And Mike and I looked at each other and went, oh shit, he's right. And when you go back and look at all the x-rays you've done where it ends up in the middle of the tibia, they're all in balance. Only about 3 or 4 degrees, but it's really annoying when you start to notice it. And then you think, well, if I've done a few hundred of these wrong, and I've taught 20 people to do them, and they've all done a couple of hundred wrong, it's quite a lot that are wrong. So it's the end point for your guide wire is as important as the entry point. Less so when you talk about isthmic fractures, because to be honest, if you've got a transverse isthmic fracture with nailing, it has to be reduced. The end point's key, and on an AP ankle, which that is, it should be in the lateral third. On a mortise view, it should just be lateral to the centre. It's slightly lateral. But it's set up. Spend your time on the entry point, spend your time on your end point, and everything else will sort itself out in the wash. There's no real argument now between reamed and unreamed nails. Reamed nails. You get a better fit. You get the reamings coming out. They're just overall better. You've already had the talk on polytrauma. Have you? Yes. Good. So all about early appropriate care, the fact that you're just going to get on the nail or the long bones as soon as possible. And you're not going to worry about ARDS. It doesn't exist if they've been properly resuscitated with blood. So get on and nail it. And the tricky ones are the proximal distal fractures. No one's really going to argue that a simple pattern mid-shaft tibial fracture is a nail, and it's almost impossible to get it wrong. Other than getting your entry point wrong, which won't cause problem with the fracture, but will lead on to problems with them later on. The proximal distal ones are the difficult ones. And these are the only ones you really need to talk about, and they're about reduction techniques. So how are you going to get this reduced when you're nailing it? So John, what's going to be the problem with this when you try and nail this?
So potentially tip into bearish.
Yeah, but what's the main problem? How am I going to nail this? Yeah. So what positions are they going to be when they're
So
in
you're
the
going to flex, so you're going to get flexion of the distal fragment and extension.
Yeah, so you're going to get basically flexion and fracture. And what you end up with is your entry point to your anterior. So if you concentrate on entry points, it'll sort itself out. But reduction techniques, you can use clamps. I really hate seeing you intensify build of a clamp on a closed fracture, because you've opened the closed fracture. But you haven't opened it properly in a neat way. You've just made two little spike holes in really bruised skin and crushed it with a clamp. Not very happy. So you can clamp them, tend not to. You can just be aiming intensive about your start point and your end point and your position, and you make sure that when you flex them, your hand is above the fracture. You make sure your entry point's good. You make sure your wire goes down well. And anyone that's worked with me knows I'm a little bit anal when it comes to positioning and getting everything just right. You can use temporary plates. So temporary plates are certainly well described in the literature for this type of fracture. Preventing flexion deformities, proximal fractures when nailing, using an anterior, using anterolateral, little 3.5 DCP, 4 screws to top to bottom, just to get that anterior apex keyed in so it's easy to nail. Or you can use polar screws, or polar wires, or polar pins, I don't know what you want to call them. Who knows what polar means, or where it comes from?
Do the big concrete things in tires.
Yeah, it's a bollard. It's German for bollard. And that's what it is. Everyone sees it's like Mr. Pollard. It's not. It's just a bollard in German. And it just blocks your nail. And basically, if you imagine that fracture, that nail is going to want to skirt down the medial side of the proximal fragment, a little bit of bounce. And it's also, on the lateral view, you know it's going to want to go a little bit posterior and leave your fracture flexed. So if you want to put a blocking screw in, you put it where you don't want the nail. And there are different techniques, and Alex and Pete from London teach it very differently to me, and that's fine. There are different ways of doing it. They do it a complicated way, which is very good if you use a super technique, because they basically bang the nail in and out and in and out a few times. And wherever the nail keeps going, they just put a screw, just stop it going there, and it works. And it's fine. It's very simple and almost idiot-proof. I like to do the complex way, so I use a lot of them. So in the proximal fracture, I will just put a posterior blocking wire in against my long guide wire. The long guide wire goes in after the perfect entry point. I put my blocking wire medial to lateral behind that so that it won't flex. And if I want to on the AP view, I might also put one, in that case, I'd go lateral. Sorry, medial to my long guide wire. And then as the nail goes down, those wires will hold the nail and stop it going in the wrong place. The easiest way for me to think about blocking screws and blocking wires is you want to put them in mobile fragments, so you don't want to put them in the diaphysis. Because actually, if the nail is wedged at the isthmus, you physically can't move the nail in that segment. So the proximal fracture is in the proximal segment, in the distal fracture in the distal segment. And you put your blocking wire on the side of the nail, you want that fragment to move. So if you put it posterior in the proximal fragment, you will move the proximal fragment posterior as the nail goes in. So you go from flexion deformity to nice and straight. I prefer using wires for acute fractures because they're slightly flexible, so if you've overcooked it, there's a little bit of leeway in them. They're also free because you've already used it for your entry point. I am tight. And you can just fracture them, and if it's not quite right, that's fine. You just get a second wire, and you put it a little bit more through. Or if you've gone too far, you just take the wire out and back in again. Just be very careful with using smooth wires if you're reaming. If you're reaming, you have to put a clip on the wire, because as the reamer catches the wire, it will either spit it out across the room, or it will shoot it straight for the patient and out the other side. I've had both of those happen. You learn the hard way. So that's your polar position. So if you want to move that proximal tibia over the lateral side there, you block the wire lateral to your guide wire. You can use screws. You can use wires, you can use R pins, you can essentially do whatever you like. I think if you're doing acute fractures, you only need temporary blocking fixation, so wires are absolutely fine and they're really easy to use. And then once you've locked proximal distally, you can take them out. If you're doing a bit more complex correction where you need more force, I would tend to use a 4 mm chance pin while I'm reaming and change that for 5 mm locking bolt before the nail goes in. Never ream up against the locking bolt. I don't get tricked into using a locking bolt as a blocking screw. If you're going to ream against it, when you've got high-speed steel versus titanium in your winner, and it's not a titanium locking bolt, your reamer will just go straight through the bolt. Like it's not even there. The keys are entry point, line reduction techniques, little mini plates with perforated incisions. You can leave them in, you can take them out. Examiners, you take them out. But you can leave them, they don't tend to cause a problem. But the key is you don't leave it malreduced. Circular frame fixation. I wouldn't have a frame on my leg. There is feasibility RCT on the moment, I think, looking at circular frame versus nail fixation of segmental tibial fractures. The outcome of that study will show it's not feasible to recruit to that study, but they'll do it anyway. So frames, in a lot of times, are sort of limited to what they consider unnailable extra-articular fractures. I don't think there are any unnailable extra-articular fractures. Or segmental injuries. People worry about the middle segment spinning. I've never seen that happen. I've nailed plenty of segmental tibial fractures, and I have never seen the middle segment spin when the reamer goes down. So these sorts of pattern fractures, that long middle segment, don't worry about it, but concentrate on bone fractures. They both have to be reduced. You can't ignore one, they both have to be dealt with. It's just a bit more awkward. So this one's a little mini plate, tiny little entry point, long guide wire, nails, happy days. Anterior knee pain and nailing, I mean on my high horse now, there is no evidence behind this, it's at least level 8. I don't think tibial nails cause anterior knee pain. Provided they're done right. If your entry point is right, as per that image intensified film, so your entry point is on that bald area of the tibial plateau, just in front of the intermeniscal ligament, you're not going in through bone attached to the back pad, you're not going in through the tibial tubercle, which I have seen. You're not doing damage which will cause anterior knee pain. I think most anterior knee pain comes from the tibial fracture. So when the physio sends the patient back, and the patient says, "Oh, the physio told me I'm going to have my nail out because it's causing my knee pain." You look at the X-ray, and it's 10 minutes below the joint surface, and you think, "I'm going to cause you some knee pain, get this out." Very, very closely examine them. Their knee pain is not the entry point. They might have some discomfort on the scar. I completely accept that, but scar desensitization is very, very easy. Their pain, in my view, in my experience, tends to be lateral patellofemoral facet. So they come in and they go, "I've got really bad knee pain, I'll be told to my nail out." Where's your knee pain? Here. Or they describe that classic patellofemoral band of pain underneath the patella. And then you watch them walk, they've got a tight gastroc and they walk the legs through a rotated gait, which gives you anterior knee pain. And the reason they've got a tight gastroc is they've had a tibial injury and someone hasn't cracked the width. They've gone, weight bearers tolerated, oh, just touch weight bear them, oh, it's a nasty fracture, let's non-weight bear them. When someone's got a tibial nailing, they fully weight bear. And by that, I don't mean weight bear tolerance. I don't mean weight bear required. I mean they fully weight bear from day one. They just get on with it. If they don't get on with it, you need a proper physio to make them get on with it. Because if they get into bad habits, they get a tight gastroc and they get an abnormal gait, everything goes wrong. So don't allow them to get into that problem in the first place. And when you see someone at 12 months with pain, it's not just a gastroc at that point. They've got a tight gastroc, they've got an abnormal gait, they've got tight short external rotations of the hip, and they've got weak abductors. So all of that needs addressing, and the knee pain will go away. Or you can hammer them from day one and make sure they don't get in the first place. So my view is you do not affect anterior knee pain by treating them in any different way, whether it's a plaster, whether it's a frame, whether it's a plate, whether it's a superficial nail or an interpatellal nail. that's easily nailable. How does that nail that? Basically, everyone's worked here because that's what it needs. Yeah, you might get a CT scan, but only as a pre-op planning, you want to know where to put the periarticular screws before a start. But that is an extra articular distal tibial fracture that happens to sneak into the joint a little bit. Influence. This actually might stop instead of about 2 hours ago, so. Which one's this? Oh yeah, fixed ET. Fixed ET. This is a really interesting paper or study. Mainly because it was massively biased, partly by me, because this was meant to be any fracture within 2 Muller squares of the tibial plafond, randomised to nail or plate, and see which is better. And there were a lot of fractures excluded from the trial due to surgeon preference. So if I'm not putting a plate on that, that needs a nail. And that might have been me quite a lot. So in that, the patients were still followed up. And the people who understand research tell me that that should bias the paper towards favouring outcomes with plates. Because essentially, if we think it needs to nail, we just nail it. It's only the really tricky ones we include. So it should bias it towards plates. Complete opposite. This is one of the few papers that came out absolutely black and white, plates bad. I would question a lot of the surgeons in the study, given that the infection rate in the plating group was about 15%, and in the nailing group was about 8 or 9%. Who the hell has got a 9% infection rate in their closed tibial nails? Ours is 4% in our open tips. But anyway, it's a very good paper to justify nailing everything. And the one thing you can't do with Matt Costa's papers is ever question the validity of the statistical method or research methodology. You can rip into the question and whether or not he answers the question, but they're actually very well constructed studies. Not always agree with the outcomes. Complex injuries, you can go a little bit fancy. But this is pretty straightforward when you actually look at it. A lot of people are worried like that. The nasty, very broken, clearly osteoporotic and elderly tibia. You know, you don't want to plate that. Don't really want to nail it. You certainly want to frame it along lady's tibia. But you can do plate augmented nail fixation. So you've got most of that reduced. You've got the articular element of that reduced to the plate. And then apply nail pads to reduce the metal seal portion of the fracture. Looks complicated, looks difficult, is actually very easy and works very well. And you can do it in either order. I tend to nail before I plate in these ones, depending on the exact nature of the fracture. You just got to make sure the nail won't get in the way of the plate, or your plate won't get in the way of the nail. So I think in the argument of nail versus plate versus frame, for most tibial fractures, there isn't an argument, it's only nails. If you're in a big framing centre, yeah, fine, frame it. People do well with frames. I personally wouldn't have one on the length of time it's going to take. In Sheffield, you know, there are 2 ways of managing a tibial fracture, or 3. Plaster, frame, amputation. When it comes down to entry point, so whether you do infratellar or supratellar, I think supratellar nailing has its place. I think it's more useful in proximal tibial fractures. It limits inflection deformity. But it is quite technically demanding. It's not simple. It's not just, oh yeah, bang it in, it's nice and easy. You still have to do all the reduction maneuvers you would be doing with an infratellar nail. Don't assume that just because the leg's almost flat, that it's not going to flex. It will still flex. Don't assume it's not going to balance. It will still going to balance. You still have to do all the things you would normally do. And you have to be damn well sure that you are not reading out the PFJ, which does happen and is negligent. But I don't think, personally, it has huge advantages over infratellar nailing. And I do see a lot of problems with it. But as I said, old dog, new tricks. I don't think there's anything wrong with it, but whatever you do, do it well. The complex fractures are the ones that we see more of here, and as everyone rotates through, you'll see them all, and they'll change from being complex fractures to being slightly awkward fractures. They're actually very easy. You want the joint at the top and the joint at the bottom to be lined up, and you want everything else in the middle to be splintered. And you can use just a nail, you can use a nail blocking screws, you can use a nail and a plate, you can use just a plate. But if it's an extra fracture, you want the fully weight bearing, the best thing to weight bearing with is a nail. You might just need to add in a few extra steps to allow you to get that nailed. There we go. Reduction techniques. Again, most trauma, you just learn by doing it. And it is very, very clear in the exam, those that have done it and those that haven't done it. Just do it. The more you do, the better you become, the more relaxed you become about it, and the more different techniques you're exposed to. So here we're very biased towards trauma, but at the same time, there are lots of very good surgeons trying to read it who are very, very good at trauma. Learn from them, learn their techniques, and develop your own technique for exactly what you want to do. I'm a big fan of polar screws and polar wires and tibial nailing. Mike doesn't really like them. He tends to do little mini-percutaneous plating to fix them. That's absolutely fine. Steve down at BRI will tend to do super tongue nailing and use a half ring frame to get it reduced. All three of those are very good techniques. I prefer one, Mike prefers one, Steve prefers one. But actually, your job as trainees is to learn all three of them, or more, and work out how you want to do it, rather than me standing here and telling you the best way of doing it. Happy to teach you the best way, which is my way. But there are different ways of doing it, and they're all fine, provided you do what you're good at. Any questions? On plateaus, on pylons, on tibial shafts, on open fractures, because we haven't touched on open fractures, because that's a whole day by itself. Or is it just Friday afternoon, 4:10? We're all going to. Perfect.
Yeah, that's right.